We might continue the questions and answers later on. Thank you. Now, I am very much honored to present to you Philippe Pernigo, who is a well-known speaker, and we will talk on opening wedge tibial osteotomy for large varus deformity. Please.
Thank you. I am a hip and knee surgeon, and I perform many arthroplasties, but I still perform high tibial osteotomy. I have a large experience since I've performed every week about 4 or 5 high tibial osteotomy with opening wedge technique since 1980. So what's a large varus and what's a large osteotomy? It's about 20 degrees of varus. This is an example, 45 years old, 22 degrees of varus and high tibial osteotomy with opening wedge technique. Probably you have 3 situations. Of course, the treatment of a varus osteoarthritis, I will not speak about LCA insufficiency. There is another situation today. It's the association with arthroplasty to avoid release with a large varus deformity. And I perform at the same time, the same day, the same operation, high tibial osteotomy and total knee arthroplasty. And the last point you have to know, it's how to deal with the total knee arthroplasty after you have performed an opening or closed wedge osteotomy. So quickly, I report for the first time in 1987 in the American Journal of Bone and Joint Surgery the technique of high tibial osteotomy with opening wedge. So I will be very short on this point since we have described just one point. The most important is the quality of the X-ray. The quality of the X-ray determines the correction. Even now, I have, of course, the navigation system to perform, but keep in mind that the best for a large varus is the quality of the X-rays first, and second, perhaps we'll see the graft. That was the first technique we used with a bone graft at the beginning. The most important, keep these pictures in mind. Even now, with tables of correction, with navigation system, the best is the quality of X-rays and the capacity of the surgeon to be able to use a graph to calculate the correction. If you are not able to use a graph for a large correction, be careful. You will be surprised. We moved to rigid internal fixation as soon as 1980. We used the technique of calculations with tables, and we will find in the literature, in the many papers I've done this table. One point after the graft is to know how to know the height of the tibia. You can, of course, measure on X-rays, but the most simple is to use your device for the screw length to calculate the height of the tibia. That's the table you can find in many papers. I still used a substitute, and I combined both a substitute and log plates for the patient. The reason is that allowed full white bearing I will not speak about that, but I have a series of patients with bilateral tibial opening wedge technique at the same times, both sides, and full white bearing immediately. And in this situation, I believe that the bone substitute associated with log screw is the only technique that allowed a full white bearing. And using a wedge, it's also more comfortable for the surgeon if you are not very comfortable with opening wedge. The bone substitute I use is a dual wedge implant, 2 parts, one solid for the cortical, and the other one, the porous for the, of course, the spongious bone. And you have a device to perform that, just a quick description. And we use also a block and break ancillary. It's with locking screws. So important association of a wedge and of lock plates. Some points of the technique. In the technique, you have to do 2 things. Opening medially, but not only medially. It's also important to open posteriorly. That's very important to avoid to increase the posterior slope. It's particularly important when you perform your tibial osteotomy for sport injury, for ligament insufficiency, for example. But it's also important for patients with osteoarthritis because later you will have to put probably arthroplasty. If you increase the posterior slope, you will have some problem with the prosthesis. Next point, how to avoid disruption of the lateral cortex. On the left, you have a technique, and this is the opening osteotomy is performed at the tip of the peroné. Don't use that for large deformities, except if you have a large experience with tibial osteotomy. When you increase the size of the osteotomy, do like on the right. Go to the peroneal tibial joint, because this joint acts as a hinge and avoid disruption. Of course, you may say that you may have problems later with the tibio-peroneal joint, but clearly, with an experience of more than 30 years with this technique, that does not avoid. It does not exist. This is an example. You can direct the opening to the tibio-fibular joint. Use a rigid internal fixation, and of course, you have to give to the good shape to the plate. And the wedge is posterior, and the plate is on the wedge. Some results, you see, probably most of the surgeons will not use tibial osteotomy for the patient, but rather arthroplasty. But after 25 years, this is the results. You can have some opening of the joint on the medial side by fibrocartilage. Today, I use in situation as I associate stem cell surgery in the cartilage and tibial osteotomy at the same time for young patients. Another example with 22 years of follow-up. What can you obtain as survivorship? At 10 years, about 85%, and at 15 years, 68%. So not exactly the same as for an arthroplasty, probably less than for an arthroplasty. But keep in mind, these are young patients. So advantage, of course, it's you keep the capital deformity, you keep the bone capital stock. You have some limits. Probably the limits is about 25 degrees of correction, even with some experience. Keep in mind also, you have no risk of patella bara when you open not only medially, but also posteriorly. Open posteriorly is as important as medially in large deformities to avoid patella bara and to avoid to increase the posterior slope. You may have some mistakes like these two cases if you don't respect the sagittal plane as the medial plane. So next situation is totally arthroplasty associated with tibial osteotomy at the same time. You can perform in the same patient tibial osteotomy with opening wedge and total knee arthroplasty for large varus correction. Even if you have some experience with knee arthroplasty, it's not so easy to perform a release and to balance the release after 50 or 20 degrees. If you don't want to perform a release, and in my situation, my experience, I believe that the release is very difficult with large varus deformity. I prefer to do at the same time tibial opening wedge tibial osteotomy and TKA, and you avoid any release, and you have it exactly as you perform in a normal joint. First, is an example, large varus deformity, and so first you perform tibial osteotomy, and it's just about half an hour. You put the bone substitute, the plate, some screws, 4 screws, and after you perform the knee operation, the total knee arthroplasty, exactly as it was a simple knee, because you have corrected. We have an EP knee ankle of 0 degree of varus. And you continue the arthroplasty very quickly. And you can graft, of course, the osteotomy in this situation because you have bone coming from the resection of the condyle, and you graft, of course, your the osteotomy with bone coming from the arthroplasty, and you allowed with a short stem full wide bearing for the patients. Now we have more than 10 knee with TTA and osteotomy at the same time. We have probably 20 patients, but report my first series of with Varus knees of about 22 degrees of and no complication, full wide bearing and healing of all the osteotomies about 2 months. And the patient was allowed with a full wide bearing according to the lock screws and to the short stem. This is an example, more than 20 degrees, no release, high tibial osteotomy, and knee arthroplasty at the same time, 0 degrees, perfect alignment at the end. So this allowed to perform a knee arthroplasty in large varus deformity with preservation of the patellar height. It is quite impossible to keep the patella at the good level with release, and of course you have no balance of ligament. Last situation is how to perform a total knee arthroplasty after an opening or a closed wedge osteotomy. It's frequent today. What's the best? Opening or closed for later. First, and I really recommend to avoid horizontal incision. As you perform an osteotomy, keep in mind that probably you are not the last surgeon. The patient probably will have arthroplasty later. And the first is to perform a longitudinal incision, never horizontal incision, whatever closed or wedge osteotomy, because you may have skin necrosis later. That's the first point. According to the level of joint space, of course, if you have a closed wedge, like here, the medial compartment is at the good place, and the lateral is not at the good place because you have removed bone. If you are doing an opening wedge, the lateral compartment is at a good level, so you can judge of the possibility to have the level of the cut on the lateral compartment. That's the difference. Next point. With after closed wedge osteotomy, particularly if there is, of course, if it was a large correction, you may have a risk of impingement of the lateral cortex that does not exist on the medial side with an opening wedge osteotomy. For example, this is a closed wedge osteotomy with a large correction. It was necessary to have a special device to treat these patients. And this is, of course, this is avoided with an opening wedge osteotomy because after closed wedge, you remove bone and you have the disruption of the lateral cortex on the tibia and some problem with arthroplasty later. And this is an example, another example. This is another example after closed wedge osteotomy. You have to use a special device. So this problem does not exist after an opening wedge osteotomy. And I will say I perform a lot of osteotomy since more than 30 years with opening wedge. But the most advantage of an opening wedge osteotomy is clearly for the total knee arthroplasty later. I know also the closed wedge. I have nothing against the closed wedge, but keep in mind that most of the patients will have later an arthroplasty, and the most advantage for the arthroplasty is clearly the opening wedge technique. Because you have not impingement, you have keep the bone stock, and you have conservation of the bone stock, level of joint space, no change, no pearl, nerve palsy, no compartment syndrome. And so keep in mind that the first is to think about the knee, and keep in mind that high tibial osteotomy is still a good surgery for the patient. Thank you for it.
Thank you. Thank you.